Good afternoon, everyone. Good afternoon for Central and Eastern times, I guess. And welcome to the inaugural session that's hosted by Young Physicians Committee. And so it'll be an opportunity to ask any questions that you may have in front of our panelists. I'll just quickly dig in. I'm the Director of Dermatology at IDI in Chicago, and I'm also chairing the YPC. I'm joined by Dr. Atam Mushiri. He's an assistant professor at NYU and also their Dermpath Fellowship Director. We are joined by our committee members. I ask committee members, for the sake of time, to write their name and where they're coming from as part of their introduction in the chat box. We are joined by four esteemed panelists. I'll start with their introduction, starting with Dr. Steve Billings, who completed his pathology residency at Indiana University School of Medicine, Indianapolis. After residency, he completed a fellowship in soft tissue pathology at Emory and subsequently a Dermpath Fellowship at Indiana University. He joined the faculty at IU School of Medicine, where he practiced for several years, and in 2007, he joined faculty at the Cleveland Clinic, where he serves as the co-director of the dermatopathology section for 15 years. He staffs the soft tissue pathology service and is also a professor of pathology at the Cleveland Clinic Lerner College of Medicine. His research interests are in dermatopathology and soft tissue pathology. He has authored 228 peer-reviewed articles, numerous invited reviews, over 100 book chapters, and co-authored 8 books. He serves on the editorial boards for many journals and has served numerous roles for professional societies, including board of directors for the ASDP and the US USCAP. And he was past president of the USCAP in 2024, so very recent. So welcome, Dr. Billings.
Thank you.
We are also joined by Dr. Timothy McCalman, who is an internationally renowned board-certified dermatopathologist who has served as a professor of pathology and dermatology and co-director of UCSF Dermatopathology and Oral Pathology Service for almost 30 years. And he departed as a professor emeritus of pathology and dermatology and is currently affiliated with Golden State Dermatology. During the last 3 decades, he has earned a distinguished reputation for both primary diagnosis and loves all diagnostic dermatopathology, but has a special expertise in the evaluation of melanocytic tumors, cutaneous lymphomas, and adnexal tumors. He has been a past editor of the JCP and is also an active member of the ASDP. So welcome, Dr. McCalman.
Thank you.
Wonderful. It's my distinct pleasure to introduce both Dr. Randy Kim and Dr. Catherine Chung. I will keep it a little bit shorter. So first we have Dr. Randy Kim, who is achieved the rank of associate professor at NYU prior to moving over to Mount Sinai University in New York. And then most recently, she's been affiliated with Dermpath Diagnostics. Dr. Kim is an active member of the AAD, ASCP, and is known nationally and internationally for her excellent and leading work in artificial intelligence in dermatopathology, and gives lectures all over the country and world around that topic. And so I'm very much looking forward to hearing her impressions about AI and how that will and has impacted our workflow in Dermpath. Welcome, Dr. Kim. Thank you so much for coming. And also, we are joined by Dr. Catherine Chung. Dr. Catherine Chung is professor of dermatology and dermatopathology at The Ohio State University, where I had to say that, where she also serves as the fellowship director for their dermatopathology fellowship. She has expertise in cutaneous lymphomas, both from the clinical and the histopathologic side of things, and was recently elected to the board of directors for ASDP. So we're very lucky to have her continued advocacy in our subspecialty. And welcome, Dr. Chung.
Thanks, Ata.
Thanks, Dr. Mushiri, and welcome to all our panelists. Just a quick housekeeping and the format of this webinar. The first half will be dedicated to questions from our committee members. We'll go around the room and our panelists will answer those questions. And the last half, or the second half, will be directed by the questions from the attendees. So attendees, if you have any questions, please write it down in the Q&A box and not the chat box, please. And if you and I will direct the questions to a specific panelist so that there is a balance of answers from everyone. So without any further delay, we will go around the room, and the first question will be from Dr. Amar Mirza.
All righty. So my question is, in your transition from training to independent practice, how did you balance adapting to a new institutional environment with staying rooted in the diagnostic framework that you developed during your residency and fellowship?
I will direct this question first to Dr. Billings. So the question, if you already got, like, we are trained kind of in an academic environment, and we may start in a private practice or different academic environment. How do we accustom ourselves to that?
Well, I think one thing that I first did, I mean, obviously I didn't have a big transition when at Indiana University because I had trained there, but when I moved to Cleveland Clinic, I had to learn the different local language. So when I first came to Cleveland Clinic, I just sat in on some sign-outs with my colleagues just to sort of see what language they use, because they use different language for dysplastic nevi versus what I was used to, and different sort of little idiosyncrasies. Like they always made sure we said invasive squamous cell carcinoma here as opposed to just squamous cell carcinoma. And I just had to learn the language because you need to make sure that you adapt to the language that your clinicians are used to using. And I think just sitting on sign out for a few times before I started signing out was very helpful.
Great. Dr. Chung, same question directed to you.
Yeah, very similar. I mean, I was fortunate enough to continue as faculty at Penn State, where I'd done my fellowship for 4 years before transitioning to OSU, where I've now been just over 8 years. But coming here, you know, everything was different. So very similarly, what clinicians wanted out of
collectively
different.
It was fun seeing us try to open this thing.
One of the things that was really dramatically different was that where I was, so at Penn State at the time anyway, we didn't give any types of margins for any types of biopsies, including pigment lesions. And then suddenly here I was, and everybody wanted margins on various things, and different clinicians want different types of margins on different things. So I think a lot of it is just getting to know your clinicians, letting them know that you are receptive to their input and you're there to support them just as much as they're there to support you, is really key. And it actually at first can be a little bit daunting depending on how big of a practice and how many clinicians you're dealing with. But I think it's certainly far from insurmountable, and you know, ends up being an easy adjustment. And once you learn everyone's ways, it actually can be kind of fun. So that's my kind of take on that.
Thank you. Yeah, I think knowing your audience is the key. Next question will be from Dr. Rohr.
I'm so sorry, I'm about to pop out for clinic if you wouldn't mind going ahead. Thank you.
Sure. Dr. Betty.
Yeah, hi. For those in both clinical dermatology and dermatopathology, how did you find a balance early in your career, and how has that changed over time? Also, how do you balance clinical responsibilities and academia?
I will direct this question to Dr. Chung first, and then move on.
Oh, that's probably one of the hardest things that I continue to encounter since I do both clinical dermatology and dermatopathology. One is knowing ultimately what your goal is. And so that is knowing that, you know, how much of each thing you want to do, and continuing to let your leadership know if you're skewed one way, like doing too much clinic, that your goal ultimately is to go the other way. It probably took me a good 8 years before I felt like I was managing my time well between clinic and dermatopathology. So I would say it's not something that can be achieved overnight and will probably take time. But it's really knowing yourself and what you want to do. And right now I do 3 half days of clinic. The rest of my time is doing Dermpath and administrative duties. And that for me has been a great balance.
Thanks, Dr. Chung. Dr. Kim's same question to you.
I agree completely with Dr. Chung. When I think about a career in academia, I think of it as a service career. And the components of an academic career is not just the clinical, but you have service to education, leadership, and possibly research. And so when you start your career, when I started my career, I thought about what that might look like. And for myself, I wanted my clinical service to be primarily Dermpath. And so one of my asks when I first started is that I didn't want a faculty practice because I felt that that would divide my time and attention. I really wanted to focus on being an excellent dermatopathologist. So what I had asked for was that my clinical service would be as part of education, that I was in the resident clinic as a supervisor. So I've never actually had my own clinical practice. So that's how I developed my clinical service that way. And as I became more confident in the Dermpath skills, that's when I decided to take on more leadership roles or take on more educational responsibilities. And so I think the idea that you have to be running at 100% in every single one of these areas is just not feasible. And your career will develop over time, and you have some agency on how you want to shape it if you, like you said, you know yourself well.
Yeah, I agree. I think like even with pathology trained dermatopathologists with different subspecialties, you have to find your own niche and build on that skills. We'll move on to another question from Dr. Mashiri.
Great. Do you want me to skip down to mine, or do you want me to ask Dr. Roars?
Dr. Roars, please.
Great, absolutely. Okay, so Dr. Rohr offers this question, which is, how long were you in practice before you felt your efficiency and confidence improved?
And back to Dr. Randy Kim.
So I came across this graphic that I was hoping I could share, but there's not a way for me to share it. But it's knowledge on the x-axis and confidence on the y-axis, and it has a peak very early on where you think you know everything, and then it goes to a nadir, and I think of that peak as residency, and it drops to a nadir at kind of fellowship and first year out of fellowship, and then it kind of has this up and down trajectory, but overall the slope is up as you advance in your career. And so what I was told was that it would be about 3 to 5 years after fellowship where you kind of start feeling like, you're getting into it. And I found that to be mostly true for myself. After 3 years, I felt like I could work up most cases on my own before having to show something. And then about year 5 is when I stopped panicking when a clinician would call. And in terms of my fellows, I would get a lot of texts from them, maybe in their first 2 years after fellowship, and after that, not so much. So I think the 3 to 5 year range is when you start to get into your groove.
Thank you. And Dr. McCalman, same question directed to you.
I have a little bit more optimistic time frame in terms of feeling comfortable. I did start out at a simpler time because that was over 30 years ago, and so there were fewer technologies to feel comfortable with. But I think that really a lot of confidence comes in the first year. What I did as an annual check-in early in my career is I kind of mapped out what I thought I had learned in that year, what I had mastered. And really the first year after fellowship, the first year of professional practice, that year, there was such a leap compared to all the other years. For the longest time, I thought, it's kind of sad, but I did this big leap in year 1, and then the other years, I continue to move the ball forward, but it's not nearly as much. But then what was sort of a fun thing to have happen was about 20 years in, I had another big jump. And there's something about the cumulative experience that you get that it's something that you can look forward to. So my answer is that you feel a lot better after 1 year. I'm sure the 3 to 5 years you'll feel even better yet. But then as you have an extended career, you just have a deep knowledge base to draw on, and it really can provide a lot of fun and comfort in your professional situation.
And what I found interesting is like your length of report is kind of inversely proportional to your experience. It kind of gets shorter and shorter.
It's correct. You can definitely say a lot without saying anything, and that probably is a good thing to happen in years 1 and 2. So.
Right. Dr. Rohr has to go in and out of the clinic, so I'll have her ask the next question.
Thank you for your flexibility. Sorry about that. Speaking of clinical and Dermpath balance. All right, so how long were you in practice before you felt your efficiency and your confidence improved?
Oh,
so we just questioned that, the same question. So that was the.
Oh, that was, you asked mine for that. Okay, I can go to
Yes.
my other question. Sorry,
Yes.
I missed it since I was in with a patient. Do you have scope sign out rules for your learners, and how do you foster a respectful and efficient learning environment?
And this will be directed to Dr. Chung.
I have a couple rules, but when I heard this question, I thought maybe I should have more rules. Yeah, we have a lot of learners, and some are really interested, and the Dermpath aspect is integral to their learning. So pathology residents, dermatology residents especially, but we also get podiatry residents, medical students from all different backgrounds, oral pathology residents, among many others. So, and others are less invested. So, you don't want to start from basics and be teaching everything to everybody, because it really does become quite inefficient. So my rules are come on time. If you are a relatively new learner and this is not integral to your learning, then I actually limit the time they are with us at sign out to no more than 75 minutes. So, I tell them show up at 10:45 and we'll end at noon, or come at 11 and you'll end at noon. And that way it kind of avoids scope fatigue or minimizes it for them. In terms of questions, then I also have a rule that if there is a question, just ask it, because it would be impossible for me to just teach everything to the point where they don't have a question. And then it would also be quite inefficient to get through sign out that way. So I try to make it a safe space as much as possible to kind of move things along.
There. I'll ask the next question. It's from Dr. Bailey. What's one thing you would have done differently in your professional journey, knowing what you know now? And first, I'll ask this question, Dr. McCalman.
One thing that I wish I had emphasized earlier, and quite frankly, it's easier to do now than it ever would have been earlier, is group sign out. So, and I'm not talking about me at a sign out situation where I've got a bunch of trainees with me. So they are basically relying on me for the diagnosis. I'm talking about group sign out where it's a group of peers. And with the way I practice now using digital pathology, people wander in and out of my office all day long. And we just look at things because I have a 65-inch screen. That's where I do my diagnostic work. And so I had some ideas for group sign out and studying it and assessing physician satisfaction. And I wish I had put that kind of thing into play. There's some issues to sort out about like who's responsible for the case, et cetera, et cetera. But the way we practice dermatopathology usually is very much a solo kind of activity. And I think that the group aspect is something that I explored earlier.
Thank you. Dr. Chung.
Okay. So to be sure not to say anything that could get me fired. I think one big mistake I made early in my career is not having all my ducks lined up before signing on the dotted line. So there were things that were kind of promised to me when I made the transition before coming to OSU. And, it had to do with like clinic time and how I was going to split my time and things like that. And, when the contract came through, it wasn't quite how we had agreed, but they said, don't worry, when you get here, we can make those adjustments. But, we just want to make sure that you get over here quickly because we know you want to join and we really want to have you. And it was like, oh yeah, all right. So, so I think those things are better worked out earlier rather than later. And it's not because anyone means any harm or they're trying to pull a fast one. It's just that it's just a lot easier to have it resolved before. And I think it saves a lot of pain and kind of, trouble down the road. So that's one big thing that I would recommend. And it's actually to the point where if anyone who's listening to this wants to reach out to me about kind of early career advice and just coming onto a new practice, I'm always happy to discuss that, behind the scenes as well.
Thank you. I would have gotten my espresso machine a lot earlier. Next question would be from Dr. Ronan.
Can you share a time when you encountered a diagnostic challenge or made an error, and what lessons you took from that experience?
And this will be directed to Dr. Kim.
Sure. So within the first 6 months after finishing fellowship, I had misdiagnosed a well-differentiated epithelioid angiosarcoma as Kaposi sarcoma. And what had happened was that it was during a time where I was being told I was ordering too many immunos, too many stains, too many levels. And so I was afraid to show this case, which looked like KS, but the clinical was a little bit strange. It was from an elderly woman. So instead, what I had done was I had asked, if you have a case that looks like KS, do you always order an HHV8? And I was told, no, you don't have to order an HHV8. So I let it go. And I got a call a month later from an outside pathologist who said, I wanted to talk to you about this case. I was sent this case, and you didn't get the history that this was a woman who had breast cancer and radiation therapy 15 years ago. And I think that this is an angiosarcoma. I'm going to work it up. Did you get an HHV8? And I said, no. And he said, I can see why you would think it's KS. It really does look like that. But he was very kind and to let me know. And then I ended up ordering the HHV8 on my case, and it was negative. But since then, number one, if I have a question, I just show it. I always order an HHV8 now for any case that I think could be KS, just to confirm it. I think that also underscores, if you're afraid to ask, you're going to make a mistake.
Right. Dr. Billings.
I think that's very good advice. Ask for help. And certainly making mistakes is part of what you've signed up for. And it's really painful when you make a mistake. And the first thing you should do is be open and honest about it, correct it, try to learn from it and try not to do it again, but don't try to bury it. And then, call a friend and say, look, I made this horrible error. And you know what they're going to do? They're going to say, I've done it too. And that helps.
I agree. Yeah. I
And
feel
then, and 6 weeks later, when you stop losing sleep, it'll start to recede from your memory.
Yeah, medicine is like a humbling experience. You keep learning. Next question I'll ask to Dr. McKelman and also Dr. Billings. What documentation or communication practices do you recommend for medical legal protection in daily practice? Or just medical legal challenges? How do you face them in daily practice? How do you avoid them?
Do you want me to go first, or?
Yes, please.
First of all, I think the thing to realize is that most medical legal errors are actually errors of communication. So if you have a plan to communicate results, that is actually making sure that you answer calls. As Dr. Kim just alluded to, asking for help or communicating to get more history. Those are things that can deflate medical legal errors, potential medical legal errors in a hurry. I see a lot of people practice protective medicine. They think that by protecting themselves by doing many stains, that they'll actually reduce the chance of error, but I'm not sure that really works. So I think it's actually better to have a standard approach that you use that's necessarily protective. Think deeply about cases, have a good strategy for working them up, and then making sure that you're resolving loose ends through strong communication in terms of limiting medical legal risk. Everybody makes cognitive mistakes, but cognitive mistakes don't necessarily translate to medical risk. I think sometimes early in careers, people think, oh, if I make a cognitive mistake, that's going to be the error that is a medical legal error, but that's not necessarily true.
I agree. And I feel like there's no such thing as over communication. While I said, like, your pathology reports become shorter and shorter, I think as long as you're clear and concise in what you want to convey, I think that's important. Dr. Billings.
I mean, I would agree with all those comments. I would also say make sure you document things well. Like if you show a case to somebody to get help, make sure it's okay to include their name on the report, but document that, because even if you both end up making the wrong diagnosis, you've done your due diligence in trying to get the right diagnosis and you've documented it. And like in consults, I'll often talk about, here's my differential diagnostic thoughts and why I went this way instead of another way. And at least you've sort of documented your thought processes. And again, document that what you've done to work up the case. You're allowed to make errors as long as you didn't sort of go against the general practice of, what is acceptable for, medicine.
Right. Take them to court with you, right?
Fill the boat.
And I think I would just add, I think it's important to understand the concepts of medical, legal practice, what constitutes medical legal practice, how the cases are forwarded to the court. I know this is out of the scope of our webinar, but I would ask, audience, they should go and read about what constitutes a medical legal case. Dr. Mashiri, next question.
So this question is for everyone, really, but I know you'll direct it appropriately. How do you think artificial intelligence will impact dermatopathology daily workflow in the next 10 years?
I will direct it first to Dr. Kim.
I think we're still very far away from AI being implemented in daily pathology workflow. There's a lot of things that still need to be worked out. To me, it's still kind of in the digital pathology phase. There's still a lot of work that needs to be done in digital pathology before it moves on into AI integrated pathology workflow. So I think we're still not quite there yet. I know people are afraid that AI will replace us, but we're just not there.
Dr. Tim McCalman.
I'll give sort of a hopeless answer and an optimistic answer. My hopeless answer is all I do when I look at slides is have an organized, algorithmic, repetitive, robotic approach to making the same diagnosis over and over again. So the hopeless part of my answer is I am actually the most replaceable person in diagnostic dermatopathology, because I look at slides in an emotion-free environment. I just make a diagnosis. You just show me the same slide a couple years later and make the same diagnosis. That tells you that I'm replaceable. But I've had some pretty deep conversations with the AI people, and my optimistic answer is closer to what Dr. Kim said. It's quite a ways off in terms of the necessary things that have to fall into place for it really to. So enjoy the career. It's going to be good. So, and we'll find a way to integrate it together with the human aspects that we provide so well. So I think it'll be fun. It'll change things, but it'll be fun.
I'll get a quick comment from Dr. Chung and Dr. Billings as well. I know OSU is big on digital, so.
Oh gosh, I don't have a lot to say except that as you've mentioned, OSU is very forward with, it was the first institution to do primary sign out with digital pathology. So they are moving fast with the AI and almost trying to convey this message that it's here, learn it, use it, otherwise you're going to be left behind. But I'm good at burying my head in the sand. So I'm actually thrilled to hear Dr. McCalmont and Dr. Kim's words, and that it's probably not as far along as many people try to make it seem.
I think it'll just be a tool that we're going to use, and it'll start out in very limited fashion for very simple tasks before it gets to the complex thing of actually making lots of diagnoses.
Right. I guess so the general message is don't be afraid. Our jobs will be secured. Dr. Mirza.
Okay, with that very reassuring panel. My second question here is, what strategies did you use to foster effective communication with your clinical colleagues and encouraging them to give you more complete and useful histories?
Never. Dr. Billings, I'll direct that.
Pick up, it used to be, before we had really good electronic medical records, I was calling clinicians all the time. And I will often say that your telephone's your second and most important tool after your microscope in terms of reach out to, if you have a question about the clinical, reach out and talk to them, because it's amazing what different information you will get from a conversation than, say, from what's on the requisition form.
I agree. And I'm sure my derm colleagues would appreciate, like they do appreciate when you call them. Call them before they call you.
Yeah, you never want a phone callogenic sign out.
Dr. Betty.
Yeah, for my second question, it was, what do you think is the most efficient and least annoying way to show a case to your mentors without doing an official consult?
And I'll direct it to Dr. Kemp.
Well, the thing that I found most interesting about that question is that phrase least annoying, because showing cases shouldn't be annoying. I consider it as part of my job, to see cases with my colleagues and to show cases. It's actually our policy at Dermpath Diagnostics to show all Spitz-Nevi and all new malignancies that are not squamous cell or basal cell carcinoma. So we have a culture where it's normal to show cases, and we have an open door policy with our colleagues. If somebody is busy, they just say, look, I'm busy until this time, can you come back then? In other places I've been, group consensus conference also worked really well. Every day at 11 o'clock, for example, we all bring our cases together and we all discuss it at the microscope. That was also an efficient way to do it. But I think that the most important thing is that you shouldn't feel like you're annoying someone if you're showing cases. And some of the junior people will say, I'm so sorry, I have these cases to show you. And for me, that's how you're going to get better. And over time, that's how you'll end up being more efficient and asking me fewer questions, right? So it's all part of developing your career.
I agree. And I guess I would also consider, like, when you're considering your first job, make sure there are people who can see your cases. I was showing like AKs and SKs in my first year to my mentor. So I think it's important. Dr. Ronan.
So my second question is, how do you handle situations when there is diagnostic uncertainty or disagreement between colleagues, especially from outside the institutions, and how are the results conveyed to clinician and what are implications for malpractice?
I'll direct it to Dr. McCalmont.
So that's a really complicated question with a lot of different aspects. So I'll try to break it down into a couple or three principles. One principle is that if there's going to be a change in diagnosis, I always use what's best for the patient as my guiding light. And so if there's a diagnosis that is outside that is incorrect, it obviously has to be corrected if there's a better diagnosis for the patient. Dr. Kim talked about a nice scenario where outside colleague called when there was a diagnostic change and commented on how it was a very challenging case and had a nice conversation about it. I try to do that whenever it's possible. Sometimes there's a diagnosis that you don't actually know exists. I know one time in the past I deeply offended a friend and they said, "Why didn't you call me when my diagnosis was wrong?" I didn't actually know they'd seen the case, so I couldn't call them. But there is a risk that you'll provoke people or upset people if you make the diagnosis different. And then the last thing I'll say is I just try to be polite. I think I've gotten a lot better at that over time. When I report a consultation or change a diagnosis, I try to find some point of agreement that I can talk about and then move on to why I'm changing the diagnosis in a different direction. I might use the strategy that Dr. Billings talked about, include a differential diagnosis that can be broad in scope and can range from what the wrong diagnosis was to what the right diagnosis is. And part of the beauty of that is it also is deflationary in a legal sense because you can show that the diagnosis had a broad range in terms of what people could think about the case, and so maybe that's deflationary in the legal agreement.
Thank you, and I agree. I think it's important to call them. It also helps build a network of people. I also don't just like call them like if I'm making a change from like well to moderate differentiated or moderate to poor. I think it's important that you understand the implications of your diagnosis, if it's going to change the treatment or not, if it's like a minor change you are doing. So don't want to like bug them just like making a smaller change. Next question I'll ask, looking back, what do you wish you had known when you started your career in Dermpath, or something you used to do in early practice that you don't do anymore, and why? As I said, mine was like longer reports have become shorter. Dr. Kim, I'll direct that question to you.
So I'll start with the second part of that question. Dr. Ahmed, you mentioned showing a lot of SKs early on in your career. In the beginning, I would show these inflamed keratoses. Would you call this reactive atypia? Is this early squamous situ? So I actually built a box of keratotic lesions and melanocytic lesions, things that I had brought to conference, and I made a recut of what it was called. This was, early CIS, this was inflamed hack, and I put in my box, and sometimes I would go back and recalibrate my degree of atypia. So I no longer do that, but I found it helpful in the beginning. And a turning point was really, there was an ASDP meeting a few years ago where they had a panel of experts that were shown a number of, routine cases, and they were asked, how would you diagnose this? And the answers were all different. So that was very enlightening for me to see that there's not always one right answer and that there's an interpretation. So sometimes I'll put that in my report. This is interpreted to be reactive atypia in the setting of trauma, things like that, so that clinicians understand that this is my interpretation of something. And the first part of the question, so that is what I wish I had known early on in my career, that there is people can look at something differently and interpret it differently, and you're not necessarily wrong.
Right. We all end with the last question from Dr. Moshiri. In the meantime, I would encourage audience to put your questions in. And Dr. Moshiri, next question from you.
Great. So how do you keep up with the literature and new diagnoses, entities, classifications while maintaining your busy clinical practice?
Dr. Billings.
That's a hard question, and quite frankly, I don't think it's quite possible to completely keep up with the literature because things are moving so quickly. One thing, I try to review a lot of papers. If I'm on an editorial board and a journal sends me an article to review, I almost always say yes because I learn a lot there. I try to at least pay attention to like the emails from the JCP and other journals about what's in the table of contents, and I scan that, and Do I read every single article? No, I don't have time for that, but I will at least click on the ones that I'm kind of interested in, try to get a sense of it. I use PubMed a lot when I'm signing out. If I have any kind of diagnostic questions, I'll do a quick search and then I'll, come up with articles. Oh yeah, I should have read that and known about that. And then I read about it. And I have really good junior colleagues who teach me a lot.
I think that's very important. All right, so that concludes questions from our committee members, and I'm going to start directing questions from our audience. So the first one is from Dr. Kibbe. As a veteran dermatopathologist, okay, how do you handle advanced tech? I'm not saying that. How do you handle advanced technology such as AI, and what roadmap should one follow to be abreast of these advances? Dr. McCalman.
Well, I think for AI, for the present time, you actually don't need to do anything. You can just practice the way that you like to practice. I do think that you need to put some thought into how you want to use ancillary techniques and what your audience demands. And so if you're doing primary diagnostic work, you probably don't need to do primary molecular work unless you want to. You can develop a relationship with a consultant or with a specialty group that you can use for those kinds of cases. If you want to do primary molecular work, then you need to think through, where's your access going to be? Is it going to be a collaboration with a national laboratory where they can do the technical component and you can do the professional component, or how do you want to structure that? And I'm happy to talk offline with anybody about how I've done that. I've had a lot of access to ancillary work in the university setting, and I know 4 years of experience in the non-university setting. It's been really a lot of fun both ways, with a lot of access to advanced techniques.
Dr. Kim?
I don't think I have anything more to add to that because, we don't really have, AI programs yet that we incorporate in our clinical practice. So I think one thing is to just be aware. There was a survey done amongst dermatopathologists asking if, dermatopathologists' general awareness of AI, and I think that was only about like 50%. So I think just becoming more aware of the technology is a good idea.
Thank you. There are a few questions from residents and fellows, but I'll get back to them afterwards. Next question is, for those of you who have left academia, what were the reasons behind your decision? Looking back, would you have made this move earlier? What advice would you give to your junior self as a dermatopathologist? Dr. McCalman and Dr. Kim, I'll direct these to you. Dr. McCalman first.
I think it's always a challenging decision to think about this. I will say that my decision was colored by a couple of different things, but really the thing that I wanted at the time I made the transition out of academia was I wanted more flexibility. So my decision was probably colored a little bit in retrospect by the pandemic, because it was a very challenging time for all of us. I just wanted to be able to have flexibility. And so I think you need to decide what's important to you personally and pursue that. So for me, at the time I made the transition, the flexibility to work anywhere was important to me. I'm presently in Seattle, and I've been working and playing with family this week. I still spend most of my time in Northern California. I do a lot of work in Portland. I'm going to be in Australia for a couple of weeks during September, and this kind of flexibility, the practice model that I've built for myself, it's very possible to do that. But the thing that I wanted was less commuting, more family, more fun. And so that's why I made the transition, and I've accomplished all of those things. So just think deeply about what moves the needle for you and how do you accomplish it. I don't really think that there's that much difference between academic practice and private practice in terms of the goals that you can achieve in terms of a true academic sense at the present point in time.
Thank you, Dr. Kim.
Yeah, this is also a complicated question and a difficult question for me to answer because I do miss academics, and to some extent, it wasn't a choice that I wanted to make, but had to make. I felt that I had pursued every avenue that was available to me to advance my career in the departments that I was in. And I went as far as I could. I hit some roadblocks, and I had decided that those roadblocks no longer served me, and I couldn't go any further. So I left, and I'm in private practice now in a group that's very flexible in terms of volume, hours. I work when I want to, and although I miss academics, I am happier now. I have more time with my family, and yeah, so it's just different choice, and it
Yeah,
works for me right now.
Yeah, I echo with Dr. McCallum and Dr. Kim. Like I made the switch like after 2 years in practice, and for various reasons, and I feel like I'm more happy. There's more flexibility. I wanted to stay in academics, so I kept my appointment. So I'm still in the Chicago area, so I still go and teach, but at my own convenience when I want to.
I guess I would offer the flip side of just staying in academics is also a good choice too. I have plenty of flexibility in my job.
Of course. Is there anything you wish you would have done while going through the fellowship? Dr. Chung.
Oh, what a difficult question. You know, I wish that I had had more experiences to build humility earlier on. And I really think that would have made me a better human being and clinician and dermatopathologist sooner. So, you know, I was single as a fellow. I had no commitments. I had no ties to where I was. So, you know, all I had to do was work and read. I didn't even have a bed, so I didn't really have a lot to do, you know. But I think about it, I wish I had been exposed a little bit more to other life experiences so that I could just understand better where other people came from, people who are balancing all different things. So that's one thing I would change. So it's not really anything about like seeing more cases. You're going to get great training wherever you go. You're going to have great mentors. So those things fall into place, but it's those other life aspects that I think sometimes we overlook.
Thank you. Dr. Chung alluded to this question. For pathology-trained folks, how do you recommend negotiating subspecialty signing or derm or other subspecialty, or limit general sign-out so we can focus on Dermpath? I think you have to negotiate with your practice, but Dr. Billings, do you have anything to add?
Well, I think it really depends on the practice that you're going to, right? I mean, at the Cleveland Clinic, we're completely subspecialized. I cover 2 specialties, but like Dr. Ronan only covers Dermpath. It really depends on the institution you're going to, and you need to be aware of that when you're going there, because not every practice is going to be completely subspecialized. It's going to be sort of partially subspecialized, or not even subspecialized at all. And sort of, you're going to have to respond to the needs of the practice.
Exactly. What are top 3 things you found extremely helpful in the first few years of transitioning from trainee to attending? Dr. Kim.
I think number 1 is to be humble. This is a really difficult job, and you need some amount of humility to know that there are things that you are not gonna have seen before. So I think that's important. I see some people just out of fellowship, and it's like, it's a I think I see people who it's a level of respect that you need for this field. It's very difficult. So that's one. Two, I think that there's some value in trying to work up the case for yourself before showing the case. You know, sometimes, you know, you're very busy and you just want somebody to tell you the answer. Please tell me what to order. But I think there's some value in trying for yourself. And the third one is, I guess, self-care. I think that's also really important. That's important for any part of your career, but to identify those places where you can practice self-care.
Agree. Like the best advice I got during my fellowship was you are not going to see everything in Dermpath. You're going to keep learning. So I agree. How do you, if you do at all, address providers who consistently provide biopsies with insufficient amounts of tissue for confident diagnosis? Who want to take it? I'll just open it to
I can take that one. I will often put in a comment that the superficial nature of the biopsy significantly limits the interpretation. And if it, you know, and the other thing I used to do is I used to have a biopsy review conference for my dermatology residents where I would sit around a microscope and we would review all their individual biopsies, and they would see whether or not they were giving me really superficial garbage or actually a real biopsy.
We need some New York-based dermatopathologist to answer this question.
I think one of the big things you should think about isn't actually the crappy nature of the biopsies. And putting snarky comments in the reports, I have considerable expertise at this. I love doing it, but it really just doesn't. It doesn't move the souls of the clinicians who give the bad biopsies or the bad histories. But I think the real problem is that the system has changed. And so in the old days, we got requisitions with a clinical history provided by a person who wrote it in pen, and now we get automated histories from people clicking buttons, especially when they use the system. And I have called physician's assistants, I have called dermatologists, and I've told them that these histories stink, and they say, Tim, you don't understand. I'm too busy. I just have to get out. So it's a significant issue. I think probably in certain group practice formats, you get better histories, and in certain freestanding laboratory, you just get what the EMMA system provides, because EMMA is the health record that's providing the automated histories to a lot of us. And you can try to coach the people to a better spot, but it can be a hard road. So I just do the best I can. I mean, I really trust the slides, which is a good mechanism for me. I do go back and look up the history to get the history in certain situations. But if I had to call about every single case, that's obviously a big drain on my time. So that's not an option that I personally am going to exercise. So I think it just remains a problem area for.
Thank you. Next two questions are kind of similar. How do you find the job? Is it through networking, or is it like through AAD, ASDP postings? I'll interject there that I think the best jobs you get are through referrals or networking on both sides, like people, if you're trying to recruit or if you're trying to find a job, I think that's the best way, but I'll direct the question, whoever wants to take it. Dr. Chung.
I will say that I got my job not through any type of posting, but just asking people I knew if they thought there would be something where I would be a fit, or they could use my skills. And in fact, when I reached out to a former resident from Penn State who was at OSU, and they said, you wouldn't happen to be looking for a Dermpath who also does cutaneous lymphoma? And the answer was, as a matter of fact, we are. So you just never know. And that's probably the avenue I would go, is rather than looking through random postings, reach out to people that you know.
I agree. Dr. Kim.
Things can change in an instant. The status of one practice's openings And so you just have to keep your ears open, keep in contact with your network. So I agree with staying, the job postings probably aren't as helpful as reaching out.
And best jobs are also not on the postings. A few of the last ones. When on the job hunt, how do you recommend getting a sense of the open door culture in terms of showing cases without feeling like you're bugging your colleagues, especially applies when interviews are virtual? I would not take a job without going in person though. But I'll direct the question to Dr. Chung and Dr. Billings.
I'll let Dr. Billings go first.
Okay, well, in terms of when you interview, I mean, that's the kind of questions you ask. Don't just ask about, what's the pay or what's the benefits. Say, how do people handle, informal curbsides? Is that a problem? Can you just go in, you have consensus conferences, find out what the culture is when you're interviewing and ask questions. Ask that type of question.
Dr. Chung.
Yeah, I agree. I think this is the sort of information that you don't want to try and infer from like a feeling. This is something just to be direct and get a direct answer, so that you get a lay of the land.
And go in person for job at least. What are your advice on moonlighting for signing out Dermpath cases as a Dermpath fellow external to our institution? I don't know if you guys have any experience.
I don't think that's allowed.
Right. Yeah.
So I would not do it.
What quality indicators you focus on in academic versus private settings? Dr. Kim.
I think flexibility is really important. Part of the reason why some of us went into this field is for that flexibility. So where I am now, some people come in at 10 a.m. and then they finish their sign out at 6 p.m. Some of them come at 7 a.m. and finish at 4 p.m. We're not told when to show up. Some people need to leave, to take care of family business and come back. Nobody is telling me when I need to sign out as long as I get my work done. And as a mom, I have to be efficient with how I do my work. And so it doesn't make sense for me to be told you need to be physically sitting in your office from 8 to 5, just in case somebody calls. Everybody has my cell phone number. They know how to reach me if there's a case. And so that was really important for me. Comparing the academic and private setting, I found that there were just kind of these arbitrary rules that didn't really make sense, and had no impact on the quality of my work.
And know your audience, I would say, just like know your dermatologist, build a relationship with them. So if there's any flexibility you need, even in academia, they'll be on your side. Last question. I know a lot of residents and fellows, or mostly residents, that want to go in Dermpath, and they have asked how to get into Dermpath Fellowship. And I'll direct it to Dr. Mushiri. He's the new Dermpath Fellowship Director at NYU. What advice you would give to them?
All right, I'll take a stab at that. So I would definitely say that, get to know the dermatopathology community, both locally and on the national scene. So every applicant or someone who's potentially interested in Dermpath, the first thing I'll tell them is prepare something to present at the AASDP conference, go to the conference, go to the sessions, meet people, get yourself out there, be friendly, be outgoing, be interested in the field, and show that through your energy, your enthusiasm, and your connection. So this is a very small subspecialty. Everybody knows everybody, and people are, and fellowships, as a result of the fellowship match process, that sort of agreement falling apart recently. Programs are to some degree, doing what they will and interviewing people on their timelines, and spots go early and are competitive, and people are very interested. So I would say, get out there, don't don't be shy about that, and apply broadly. You know, you have to be willing to go, just like, you know, if you're a derm trained person, you have to be willing to go places to do Mohs. Not so different for dermatopathology, and same for subspecialty for the path trained folks. I would say it's no different. So I think that's the most important thing. Just get yourself out there, get known to the people, the fellowship directors, and it very much is an apprenticeship. So people tend to select fellows that they know what they're getting and they know that the person is interested and dedicated to the field.
And a great way to do is to go rotate with those people too. That's what I did. Just like go out of your institution and rotate with those people. It's 101. I would really I'm very grateful to all our panelists and all our attendees for attending this webinar, presenting with their questions. And I hope Dr. Mushiri will continue this tradition next year. So thanks again for your time and your questions. You guys all have a very great day.
Thank you.
Thank
Thank
you.
you.
Thank
Take care.
you.